Welcome to the Pharmacology module, Section 2, Cannabis Dosing. Although there are multiple active cannabinoids found in the cannabis plant, THC and CBD are the most commonly measured when it comes to strength and dosage form. CBD is a non-intoxicating component which has been shown to be effective for inflammatory bowel disease, seizures, depression, inflammation, psychosis, PTSD, migraines, pain, nausea, and anxiety. THC does produce intoxication, especially at higher doses, but has been shown to be effective for muscle spasticity, low appetite, insomnia, pain, nausea, and has a potential role in opioid use disorder. For a more detailed look at the individual activity of these cannabinoids, please refer to the Cannabis Plant, a Clinical Perspective module. Cannabis medications are typically labeled and classified in one of two ways. The first is by the ratio of THC to CBD found in the medication. In most states, ratios are listed in the order of CBD to THC, but several states list ratios the other way around as THC to CBD, so it is important to clarify which protocol your local state follows and to educate patients accordingly. People do frequently travel, so it is also important to let patients know that these ratios and what they indicate may change based upon where they are purchasing their cannabis medication. The second way of labeling cannabis medication is by the percentage of cannabinoids found in the product. In some states, percentages are broken down into THCA and total potential THC, as flower does not actually contain THC until it is decarboxylated. It is important to educate patients that they should look at the total potential THC percentage to get a true understanding of the potency of their individual cannabis medication. The labeling of cannabis medications by ratio and percentage can be confusing to both patients and clinicians who are used to dosing medication by milligram strength. It is important to understand how to convert these conventional labelings into a form that is easily understood by patients and clinicians. To determine milligram strength from percentage, the percentage is typically listed on a per gram basis. If you take the percentage and multiply it by the amount of cannabis being consumed in milligrams, that will give you a good idea of the amount of milligrams of the individual cannabinoid found within that dosage form. This can then be further broken down by dose to understand approximately how many milligrams of cannabinoids would be administered per dose or inhalation of medication. For example, a cannabis flower that contains 17% THC means that 1 gram of that flower will contain approximately 170 milligrams of THC. If a 0.3 gram cannabis cigarette was made from that flower, it would yield 51 milligrams in that cigarette. If a patient consumes half of that cigarette, they would consume about 25 milligrams of THC. Oral dosage forms can also be a source of confusion to patients. Some will list cannabinoids contained per dose without a clear indication of what a dose is. For example, a chocolate bar containing 40 milligrams of THC per dose may be confusing to patients as containing 40 milligrams per entire bar, when in actuality, a dose is considered 1 square of the bar. Alternatively, some oral dosage forms will list the amount of cannabinoids found in the entire bottle, and patients must then divide that by the number of doses within the bottle to determine the milligram per dose of that medication. The lack of consistency and regulations of dosing between states and individual dispensaries can result in significant patient and clinician confusion. So it is incredibly important to familiarize yourself with the products available in your local area to be able to properly guide patients as to how to best administer and understand the dosing of their cannabis medications. The primary rule of thumb for cannabis dosing is to start low and go slow. THC-mediated side effects such as fatigue, tachycardia, and dizziness are all largely avoidable when the starting dose is low and the titration is slow. Slow upward dose titration also promotes tolerance to psychoactive sequelae of THC, which is especially important to naive cannabis users. For medical use, intoxication is not the end goal of therapy, so slow titration allows for the patient to find the sweet spot of dosing where they achieve symptom relief while minimizing psychoactivity. Consider beginning therapy with a high CBD or equal ratio CBD to THC product to maximize benefit and minimize potential intoxication. The tolerance to cannabis side effects occurs rapidly with no loss of therapeutic effects. Dosing titration should occur slowly, increasing the dose every 3 to 4 days in order to minimize adverse events. Doses exceeding 20 to 30 milligrams of THC per day may increase adverse events or induce tolerance without any improvement in efficacy and should be discouraged. Higher THC concentrations can increase anxiety and may cause a patient to hyperfocus on pain due to the biphasic nature of THC. These symptoms indicate the THC dose is too high, and the patient should then be reduced to a lower dose to minimize these side effects and improve symptom relief. The suggested starting dose of cannabis medication is around 2.5 milligrams of THC once a day. For young, elderly, or at-risk patients, or those who are naive to cannabis and nervous about the potential psychoactive effects, you may start with 1.25 milligrams of THC as an alternative. After 3 to 4 days, if the previous dose is tolerated, you can increase the dose to twice a day. After this, every 3 to 4 days and onward, you can continue to increase the dose of THC by 1.25 to 2.5 milligrams until the desired effect is obtained. In the event of adverse effects, reduce to the previous best tolerated dose. It is important to remind patients that tolerance occurs rapidly, so continuing with the new dose for 2 to 3 days to see if these side effects will go away on their own is advisable. When titrating cannabis dosing via inhalation, a slightly different methodology should be used because of the difference in dose and absorption based on how long and how hard each individual patient inhales the medication. Patients should begin with 1 2 to 3 second inhalation, followed by a wait of about 10 to 15 minutes to assess the effect of that inhalation. Patients can then continue to take 1 inhalation every 15 to 30 minutes until desired symptom control has been achieved. Once the total number of inhalations needed for symptom relief has been determined, the doses can be administered continually in the future without waiting 15 minutes in between. Titrating inhalations in this manner allows patients sufficient time to assess the effect of each additional inhalation without increasing the risk of adverse events occurring. Cannabinoid dosing is typically determined based on the milligrams of THC being administered. This is due to the fact that THC produces the majority of the adverse effects of cannabis medication. Clinical studies have indicated better patient efficacy and tolerance of cannabis medication which contains both THC and CBD. This is due to the fact that CBD can antagonize the undesirable effects of THC, such as intoxication, sedation, and tachycardia, while enhancing the analgesic, antiemetic, and anticarcinogenic properties of THC. When using a cannabis dosage form containing large amounts of CBD, the dosing should still be determined based on the milligram strength of THC contained in the product to minimize adverse effects. Cannabis medications containing both THC and CBD are recommended for the majority of patients. However, a CBD-only formulation may play a role for several patient populations, including patients who are unable to qualify for or do not have access to a state-regulated medical cannabis program, patients who are regularly drug tested and unable to utilize products containing THC, or patients extremely sensitive to the side effects of THC who are unable to use full-spectrum medical cannabis products. When it comes to CBD-only formulations, there are no established dosing guidelines or maximum doses established, except in clinical studies on psychosis, which used 800 milligrams of CBD per day, and for seizure disorders, which used 25 to 50 milligram per kilogram per day. The average dose used within randomized controlled trials was 15 milligram per kilogram per day. However, many patients obtain benefits with much lower doses, around 5 to 20 milligrams per day of oral CBD divided 2 to 3 times a day, which may reduce patient expense. Dosing with CBD-only formulations may require significant trial and error in order to find a dose that works for the patient's symptomology. When beginning a cannabis dosing regimen, encourage patients to keep a dosing journal to monitor titration and the effects of each dose increase. If large doses are needed for effect or no symptom reduction has been seen after 2 or more weeks of titration, consider trying a higher potency product to minimize patient cost and improve outcomes. CBD can balance THC side effects, especially in daytime use or when driving is required, so consider a high CBD formulation in these instances. Cannabis medicine doses must be individually determined, as they depend largely on underlying endocannabinoid tone. It is important to set patient expectations that it may take some trial and error to find the right cannabinoid ratio and dose for their individual needs. Some patients display inherent resistance to cannabinoids and require doses of greater than 100 milligrams of THC per day for clinical effect. CBD-predominant preparations have fewer untoward psychotropic effects and may require significantly higher dosing for symptom relief.